Ladies and gentlemen, I am in Prince of Wales Private Hospital with Orthopedic Surgeon Dr. David Broe. Dr. Broe was operated on my knee just under 2 weeks ago, and we're going to have a bit of a chat with him today about the surgery. And there may be some of you out there who are considering knee surgery. You may have had it, or you know a friend, and this is just to kind of help you out and give you some insight into what may lie ahead. So first of all, Dr. Broe has been practicing for 6 years. He does in the region of 250 anterior cruciate ligament repairs each year, 150 total knee replacements, and approximately 100 hip surgeries each year. So first of all, we'll just talk about when is surgery indicated.
Well, it's a very common injury. I've had torn my own ACL about 20 years ago, as you know, and I've talked to you about. And the incidences are actually rising. They're not getting smaller, and particularly in younger patient cohort. So we're doing a lot more of them. It's indicated particularly in a younger patient who wants to remain active, particularly in pivoting related sports. However, the main reason I fix them is to stabilize the joint. The ACL is what's called meniscoprotective, so its primary role is to protect the medial and lateral meniscus. Without it, we know that they are at risk of further injury or damage, particularly if you have ongoing pivoting events. And there is some well-published research, particularly out of the Mayo Clinic in Minnesota, published in the American Journal of Sports Medicine last year, showing that they followed up all their ACL patients over nearly 14 years, half treated operatively, half non-operatively. And those that were treated non-operatively did a lot worse with regards further meniscal tears, symptomatic arthritis, and requiring knee replacement surgery than those who were stabilized. So they would be my primary reasons. That's interesting actually, because in 2015 there were over 1,500 articles, research articles on the ACL, the anterior cruciate ligament alone, and it's believed to be the most researched ligament in the body. Well, you have to look at the patient individually and what their expectations are, what they want to achieve in life. If they're older and they don't particularly want to get back to any form of sport, if they're managing, or if they're not complaining of instability. ACL reconstruction is primarily to stabilize the unstable knee joint. So if they feel very stable, then you might consider going down a rehabilitation pathway. There are other indications. If they've got a lot of knee arthritis within the joint, you may veer away from that. ACL injury in that type of setting is quite rare. With regards to the type of tear itself, a mid-substance rupture is very unlikely to in any way form of heal. There is always fluid through the joint, and the fibers will not join back again. In a certain small percentage of ACL ruptures, like a femoral, what's called avulsion, where the ACL rips off the femoral side, sometimes that can stick back down to either the side of the femur or to the PCL. And actually the patient can feel inherently stable. So in that subpopulation group, I sometimes watch and wait, and I go down the non-operative route. Lovely. Alright, so now we're going to talk about some recent advances with the surgery. There's a synthetic that's sometimes used for the tendon. A thicker tendon's often used to get more stability, and we're just going to ask Dr. Broe about his own preference, or just a comment really on the recent advances. What's going on? Well, my preference is always to use your own tissue. It's the best and it's the strongest, and we know that. Allograft or autograft, which is your own tissue, is in my experience always better than allograft, which is the donor tissue from the bank. I prefer not to use that. The majority of allograft we get in this country is what's called, has to be sterilized, and in order to do that it has to be irradiated,
Okay.
which denatures the tissue and weakens it.